All right. Good afternoon, everyone. It's 12 o'clock noon, so we're going to get started with our next session in the Addressing Key Challenges series of Boosters and Beyond. As you know, we've been going through the CDC's core infection prevention and control practices for safe healthcare delivery in all settings. This week, we have Mary Ellen Casey here going to be talking to us about temporary invasive medical devices for clinical management. Next slide, please. So if you're not familiar with who we are the IPRO QIN-QIO. IPRO holds the current federally funded Medicare QIO contract for the regions shown here. IPRO specifically helps support New York, New Jersey, and Ohio. Healthcentric Advisors helps support Connecticut, Maine, Massachusetts, New Hampshire, Rhode Island, and Vermont. And Clarent helps support Maryland, Delaware, and the District of Columbia. Together, we are three organizations under the IPRO QIN-QIO banner. So if anyone asks you if you know who IPRO is, or if you know Healthcentric Advisors or Clarent, you say yes, we are the IPRO QIN-QIO. And with that, I'll pass it over to you, Mary Ellen.
Thanks, Josh. And as always, we start with a COVID update. So hospitalizations are down once again, down 19.5% with a 7-day average of 1,800 hospitalizations, which is great news. The bivalent booster, again, slowly ticking up in the right direction. Over 55 million have received the updated booster dose, with a little over 42% of adults 65 and older having received that bivalent booster. The variant, again, is staying very consistent, the XBBB strains. There's a variety of them now, so you may have heard about some cases in states with the XBBB16 strain. Again, highly transmissible. Cases have been ticking up in some states, but it doesn't appear to be any more virulent than the other strains, which is good news. And we're still at 54% for nursing home residents that are up to date with their booster. So we're, again, slowly going in the right direction. So great job. So our learning objectives for today are to discuss the infection risks associated with invasive devices, to look at some strategies that support early and prompt removal of those devices if possible, and then identify infection prevention strategies that will decrease those device-associated infections. So the CDC core principle for this measure, the temporary invasive medical devices, includes 2 points. One is that during every healthcare encounter that you're assessing the medical necessity of any invasive medical device. And we'll get into that with different types of devices, primarily Foley catheters, vascular catheters, and ventilators, just in the interest of time today. And also ensuring that healthcare personnel adhere to recommended insertion and maintenance practices. So invasive devices should really be part of your infection control plan and included in regular assessments, including daily assessment of their necessity. And healthcare providers need to be knowledgeable about the risks of infection, both with insertion and maintenance of these devices, and really be an advocate for working towards removal of them. So the first one we'll talk about is catheter-associated UTIs. UTIs are certainly an area of concern for long-term care at any given day, but add a Foley catheter to it and it makes your job that much harder. UTIs are one of the most common infections in long-term care. They account for 20 to 30% of reported infections. And with indwelling catheters comes the risk of cystitis or pyelonephritis, bacteremia, and septic shock. So the necessity of the urinary catheter should be addressed on a consistent basis. When bundles were first being put together around quality, one of the most amazing things to me was, and I'm sure to a lot of people, were people had unnecessary Foley catheters in with providers who didn't even realize that they had them in. So it was an easy win to get those out because the provider didn't even know they had ordered it in the first place. So it's those kinds of things that really can make a difference by just being aware of it. So catheter indicators were developed in terms of appropriate use versus inappropriate use. And this is a guide when you're looking at your Foley catheters program and setting up criteria for what constitutes a reason for insertion of the catheter. It could be urinary retention, a bladder outlet obstruction. It's a critically ill resident, needs more strict I&O monitoring. Also, with perioperative, for certain surgeries, That's an important indicator in the hospital, but oftentimes these folks come for short stays at long-term care post-operatively, needing to have that fully in because of the surgery. They assist in sacral or perineal wound healing in an incontinent resident, which is an appropriate use, prolonged immobilization, and end-of-life comfort. The inappropriate use is convenience. Oftentimes, I know I've seen it in my own practice that patients have actually requested them. That is an appropriate use of a catheter, but I'm sure you've heard of that. Alternate strategies are not utilized, so they haven't even been considered before the Foley is put in. Specimen collection for residents who can't void, and catheter is not removed when it's no longer necessary. And quite often it's because people just forget about it. So it's just important to be situationally aware. And the other thing is these indications can change. So if you have someone who's immobilized, but they're starting on a mobility program, their status is starting to improve, or they're in PT or whatever the circumstance may be, that is one area where if someone is improving with their mobility, that can actually reduce their incidence of UTIs. And it makes sense because hopefully they can get the catheter out, they're moving, they're going to the commode or the bathroom, and that certainly helps decrease the risk. Catheters are the one area of the devices we're talking about where you have to be concerned about insertion and maintenance. So they may be coming to you with a Foley catheter, but most likely you're inserting it in your facility. So personnel need to be trained, they need to use standard precautions, hand hygiene before gloving, and again when gloves are removed. And depending on your Foley catheter supplies, I know some are more costly than others. Some of these kits actually provide the step-by-step, and all the gloves and even the tiny packets of hand hygiene are within the kit, which avoids the staff having to run around trying to collect this stuff and possibly interrupting that insertion time. So supplies are really important, and using aseptic technique when you're inserting that catheter. Using the smallest catheter necessary is really important because it reduces the trauma as you're inserting the catheter and leads to less vascular injury, which could promote bacteria. And connecting to a collection bag that's positioned below the bladder for gravity, drainage, and above the floor is also really important. Maintenance with urinary catheters. Again, the daily assessment of do we need this catheter? The longer it's in, the more increased chance of a UTI. So really important, including that as part of your care. Maintaining a closed sterile urinary draining system and maintaining that unobstructed urine flow where the tube and the catheter isn't kinked, that you're securing it per your facility protocol, and keeping the bag below the level of the bladder. So often, and surveyors look for this. We're popping the bag on the patient's lap when they're in a wheelchair, or putting it up on the bed when we're transferring them. It really needs to be below the level of the bladder and not on the floor. I worked in a hospital where they had this practice of they put the Foley bag on the floor, but they put it on a clean towel. That was the thing. Well, it's on a towel, so it's okay. So be wary of practices. Always good to do environmental rounds to see what's going on with some of these practices. Routine hygiene is important with Foley care, and you do not have to clean the periurethral area with an antiseptic. Soap and water is fine. Also, it's important to perform perinatal care after each bowel movement because microorganisms as part of stool. Again, we mentioned this through this whole series that bacteria are opportunistic. So if they have a spot where they can run rampant, they're going to do it. Switching to infusion therapies, and we're going to talk about a couple of different catheters here, the peripheral, the central, and implanted ports. And while they're very different, and some may include insertion and some are just maintenance only, they all follow some basic principles that there needs to be evidence-based policies and practices around them. You have a resident population that's more susceptible to infection, and now you're introducing devices that will increase their infection risk more. So you need to think about the catheter type, the duration of the use, how often it's accessed, catheter care, all that needs to be factored into your plan with taking care of these devices. and include them as part of your IPC surveillance plan. Having evidence-based practices, whether it's from the CDC or the Infusion Nurses Society, state and federal regs, whatever is part of your plan, it's really important to consider all that while you're monitoring these residents who are receiving infusion therapy. Vascular devices, there's general infection control guidelines, no matter what type of device you're seeing, and peripheral catheters, PICC lines, and implanted ports are among those most commonly used for infusion therapy. I think long-term care facilities, you're seeing more and more of this as patients are discharged from the hospital, even coming for short-term stays. PICCs are very often used for long-term IV care, and if they're on a 6-week regimen. And there's a risk with these catheters that the residents could contract a bloodstream infection. So you want to monitor the necessity of these catheters. Peripheral is probably the one where you're really going to be doing a daily assessment. It's important with the PICCs, however, to continue that conversation as far as catheter necessity, but oftentimes they come in with a prescribed 6-week regimen of IV antibiotics or whatever they're on for therapy, and there's usually an end date, but just important to keep in the back of your mind. There have been cases where they're sort of forgotten and they need to come out. Ports, not so much where you were going to be looking for the necessity, they're staying in, but it's important to keep an eye on those as well. Close monitoring during the delivery of therapy. If there's redness or warmth, swelling, intolerance of the infusion is important in securing these devices so that they're not pulled on, tugged on, excuse me, or manipulated in a way that causes some vascular trauma. Tubing and dressing changes are an important part of the care of these vascular devices. And just speaking in general terms, depending on your facility, what your policy is, the guidelines that you're following or the regulations, a lot of times there's a prescribed time for tubing and dressing changes. And it used to be that more often was better, but that has really changed in terms of preventing infection. That dressings usually can stay on for up to 7 days as long as they're not compromised. If you start to see them where they look wet or they're loosening, then it's really important to change them. But if everything is kosher, then it's better to leave them alone and just assess daily. Audits, I think, are really important with managing invasive medical devices. And this is an opportunity to look at all kinds of infection control practice when you're looking at these devices, looking to see, are they doing proper site care? What do the dressing changes look like if the dressing's intact and look fine? The appropriate use of PPE when you're managing these devices, as well as hand hygiene. So there's a lot that you can include in that process surveillance to make sure that folks are managing them appropriately. Folks are always concerned about, well, where does this contamination come from? And there's a couple of different areas that we look at. How does contamination occur? This is a pretty nice visual of migration of bacteria. And usually it's the resident's own skin flora that actually puts them at the most risk. So migration of skin organisms at the insertion site, oftentimes, we carry around staph. It's a common skin bacteria that we live in harmony with for the most part. But if you introduce something that's invasive, it's going to hitch a ride at the insertion site. So proper cleaning is really important to kill the bacteria at the insertion site. So that's one way. And usually the most common way is that the bacteria is on the catheter tip. It sits there and starts to spread, and then you run into all kinds of problems. Direct contamination can occur if folks are handling the catheters, the hub, just the device in general. They haven't washed their hands. Equipment might be not as clean as it should be surrounding that catheter. And so that's the second way that contamination most occurs. The line can be seeded from other infections. So if you have a resident that has a bladder infection, they would be more prone to having that bacteria spread to other sources, particularly where there's that vulnerability with an insertion device. And lastly, which is very rare, thankfully, but contaminated infusion solution. So that can really be profoundly serious, with leading to sepsis. So thankfully, it's not something we see a lot of, but certainly something to consider when you're managing IV infusion therapy. For peripheral catheters, you're more likely to be involved in both insertion and maintenance. So, we talked a lot about the ways that the skin can be contaminated, causing these lines to become infected. So there are some best practices that using the upper extremity site for catheter insertion is really best. Selecting that catheter based on its intended purpose and use. There may be a discussion in your facility about a patient that they're thinking about a peripheral catheter, but if it's a long-term use, they might want to use something like a midline, which is not a central line, but it's a little bit more stable for long-term use. And just know the complications, what's the risk versus benefit with whatever type of device that you use. And again, preparing that skin, because that's the most common source of infection. And then maintenance, again, is evaluating it to see when it can come out. A securement device to keep it stable. Scrub the hub. I hold scrub the hub as high as hand hygiene, because I don't think we put as much emphasis on this as we should. With good hand hygiene, and any time that you're manipulating that system or opening the system, to scrub the hub, the needleless connector, to clean up any bacteria that's just really congregating, waiting for its moment. Anytime you manipulate that line, you're putting some pressure and movement on the device itself. So it's important to be careful handling it. Changing your dressing per policy if it becomes wet or soiled, and removing the IV if it starts with signs of phlebitis or infection or it's malfunctioning. So those kinds of things to be on the lookout for. A PICC line is a central catheter, and it can be peripherally inserted using the brachial, bacillic, or cephalic vein. And it's advanced until it reaches the superior vena cava, hence a central line. So I'm assuming for the most part that these folks are coming into you with a PICC line in place, and it's a matter of maintenance. So it's important, again, to anytime you're manipulating the system, that you're using hand hygiene, that you're disinfecting the port, the needleless connector, and that these connectors and adjunct equipment is changed per protocol. A securement device, again, stabilizes that catheter, so it decreases, especially with a PICC line, it decreases the risk of them migrating and dislodging, which can happen, just depending on the situation. Oftentimes, with movement, they can migrate out. So and then they're not where they need to be, and an alternate plan has to happen with that. If the dressing becomes wet or loose, it must be promptly replaced. You can put a protective dressing during bathing or showering over it so that it doesn't get wet. But again, these dressings with the label on it, when it was changed, the ability to visualize the insertion site is important, and that the integrity is maintained. They can stay on for up to 7 days. And again, it really depends on your policies and procedures and your regulations. But generally speaking, 7 days is fine. If it looks as good as this one does, you don't have to change it for the entire 7 days. As far as ports, implanted infusion ports are surgically implanted in subcutaneous tissue, and they're usually in the chest, although you may see them sometimes in the arm and the abdomen. And again, the tip of the port terminates in a major vessel, hence a central line. So it really depends on where your resident is at with this port placement. If it was recently placed, then they may have a dressing on it that should be protected. If it's transparent, something that you can look at to visualize the site to make sure it's okay. But again, if they have a catheter site dressing, if it becomes damp or loosened or visibly soiled, to change that. But they too can stay on for up to 7 days if they're doing okay. Oftentimes, if you have someone with an established port, there's nothing on it. Some residents may have a Band-Aid over it, but you shouldn't use topical antibiotic creams or ointments on the insertion sites, and not to submerge it in water. It should be covered if you're showering. And visual inspection on a regular basis is important. Again, you may not even access these ports, and it's interesting. Sometimes there's been cases where patients or residents have had them, and if you don't access them, you don't know about them. And so it's really important to encourage the resident or the family to report any changes in the catheter site or any new discomfort, because again, if you're not using it or accessing it, things could be happening that you're not aware of until someone says something. Administration sets and medication assessment is part and parcel of managing invasive devices. And again, hand hygiene is really important. Anytime you're using and administering infusion therapy and handling that equipment, trying to minimally manipulate. We talked about the manipulation, especially in the long-term care population, trying to get their clothes on. It's not, and nobody's not wearing a Johnny, so so trying to get the line through the clothes can be particularly challenging. So putting an extension on, really distal from the insertion site is better than trying to manipulate it through a sleeve closer to the insertion site. It just puts more trauma on that catheter. So if there's a longer extension cord that you can disconnect, again, scrubbing the hub, leaving the alcohol wipe as best as you can on that extension, and slipping it through the clothes to get it through as quickly as you can. Challenging, I know, but it's important to think about it as part of your overall maintenance. If you're managing medications, and you may have a third party coming in doing this, or you may have a pharmacy within your own facility and you're more actively involved in this, but just be aware that medication labels should be checked with the correct resident's name, the medication expiration, looking at the medication integrity, that it's not cloudy or discolored. There's proper refrigeration storage for IV meds, which is different sometimes from other medications, and food storage. The temperature has to be between 36 and 46 degrees Fahrenheit in some cases, so it depends on your medication, but only medication should be stored in medication refrigerator. That's also important. And if you are someone who's monitoring these meds, that there's a temperature log for them, and that they're monitored probably at least daily, and depending on what you have, sometimes it's more than that. So that was kind of quick on peripheral vascular devices, but I wanted to talk a little bit about dialysis therapy, because this is an area I think that long-term care is seeing a lot more residents with end-stage renal disease. And this is really important too in terms of managing devices. Infection is the second leading cause of death among hemodialysis patients, and residents with ESRD are at greater infection risk. No surprise really when you look at the criteria for that oftentimes they need short-term and long-term vascular access, which increases their risk for bloodstream infections. They're in and out of the hospital and different healthcare centers, so they have more exposure to multi-drug resistant organisms. So more places they're going, more healthcare workers they're exposed to, and other patients they're exposed to, that exogenous pathogen exposure that I mentioned. So, they're exposed to more potentially contaminated equipment, or healthcare workers who may not be washing their hands properly. They have comorbidities, which increases their risk. They're more susceptible to influenza and pneumococcal and their associated secondary complications. So you're adding insult upon injury with this population. And it's a growing, older adults are a growing end-stage renal disease population. So we're just going to see more and more folks on dialysis. Maintenance is really key in your setting. For the most part, people, if a third party is coming in to do dialysis, you may be doing dialysis, and I don't want to assume that you're not, but for the most part, people are either going out for dialysis services or perhaps having a vendor come in. But maintenance is really very consistent with vascular devices, hand hygiene, stellar infection control practices. Being up to date on vaccinations for this population is really important because, again, trying to limit their exposure to the hospital setting, if at all possible, due to vaccine preventable diseases is important. Being aware of not only state regulations, but CMS regulations in terms of dialysis. It's highly regulated area of healthcare. And if you have a third-party vendor, just establishing that relationship with that dialysis service to be aware of what are their policies and procedures, their water testing results. Are they letting you know about any issues that they're having, or maybe outbreaks in their facility that they need to let you know? There's 3 different types of dialysis catheters: the tunneled, which is short-term and emergent, that you may see initially while the resident is waiting for a fistula or a graft to mature. And that's usually in the subclavian or the internal jugular vein. AV fistula is preferred for long-term dialysis, and it's actually less prone to infection and clotting, which is the good news, that if you have a resident who's on long-term dialysis, that the risk, while it's still there, is less. And then there's peritoneal dialysis, which is a catheter inserted into the abdominal cavity, which comes with its own risks in terms of peritonitis, something to watch for. And I put a chart here of just catheter site maintenance across all 3 of them, which most of them are pretty similar. But, again, just keep in mind that this is where infection prevention measures are really so important in this type of therapy, because so many things can happen and so many complications. The other thing you really have to consider with dialysis residents is bloodborne pathogen exposure. So dialysis puts you at an additional risk for exposure to Hep B, Hep C, and HIV. And there have been outbreaks of hepatitis B and hepatitis C in dialysis facilities. And the exposures have primarily occurred because there was a breakdown in sterile technique. There was a breakdown in other infection precautions, such as hand hygiene and cleaning of equipment, and then that led to contaminated equipment. The other thing that's strongly recommended is a hepatitis B vaccine. Even though the vaccine response is less robust in hemodialysis residents, when you compare them to the general population, it's still really important due to their increased risk. And then having hepatitis B and C scheduled testing is important for this population. And I'm just quickly talking on mechanical ventilation, because there may be facilities that don't have residents on ventilators, but if you're a facility that may have chronic ventilated patients, there's so much literature out there on ventilator-associated pneumonia and the bundle around infection control measures, but it's really hospital specific. So there is a study out there that looked at a modified maintenance bundle specifically for long-term care. And this may be something that you already do in your facility based on just reading about evidence-based practice and what to do for these particular residents and their vulnerabilities. And that's hand hygiene, no surprise. In some cases, folks are using chlorhexidine oral hygiene, or whatever oral hygiene that you're using it every shift. That the head of bed is elevated 30 to 45 degrees for residents who are supine. There's a dedicated trach cannula balloon pressure range of 20 to 30 centimeters of water. And this other intervention with the tube feeding is important not only for folks who are ventilated, but if you have a patient who is on a tube feeding, that you're looking at residual food remnants before every meal to make sure that it's minimal before you feed them again, so that they avoid aspiration, not only because of the tube feeding, but add that to someone who's on mechanical ventilation, and that just increases your risk for aspiration pneumonia. So just something to think about if you have patients who require ventilation. So in summary, invasive medical devices pose an infection risk. A daily assessment of device necessity is really important, just to keep everyone situationally aware. Limit manipulation of devices to the extent possible, maintaining that closed system. And I just always close with that diligent infection control practice, especially scrub the hub and hand hygiene. So low tech works so well. So with that, there are resources here for folks to take a look at, including bloodstream infection prevention, and that dialysis safety page on the CDC website is really, really helpful. And with that, Josh, any questions or comments?
Sure. So if anyone has any questions or comments, please feel free to put them into chat. Right now, I am taking the links that Mary Ellen had referenced in the slides and putting them into chat for your convenience as well. So give everyone an opportunity now to come off mute or put anything into chat for anything that you have for Mary Ellen.
There's a lot to consider. Every time we do these sessions, I just think, oh my gosh, there's just so much.
Yeah. Well, I'm not seeing anything. So if do you recommend using Kuros caps?
You know, I don't have any opinion one way or the other on them. I know, I guess often I personally like them, but you know, I've worked in facilities where, this may be your process at your facility, where you have the staff weigh in with a trial and they like or they don't like. I've used them in the hospital setting they seem to work well. So if something you're interested in, I always recommend doing a cost analysis and asking the vendor to you know let us trial it for like a month to see how they like them, and if you're seeing any any differences, good or bad.
And then another question, will the slides be available? So Alyssa, the slides have to go through 508 compliance, which is something that the federal government makes us do to make sure that our content is accessible for those with disabilities. So before we can send out the slides from our end to anyone, we have to make sure to get that. So once they have been approved, they should be on our series webpage for that. And we'll have information about that page as we wrap up with next week's session, because it'll be the last session of our current series. We actually are planning our next series, which is going to be starting on the 25th, and it's going to be focused, that next series is going to be focused on antipsychotic medications and as well as dementia care. So we have a lot of great content for you. We have a physician who's a subject matter expert in geriatric care, as well as dementia and antipsychotics. So be on the lookout for the new series that's going to be starting on the 25th. We have our last session of the Addressing Key Challenges, the Infection Control Core Practices, next week with Leslie Morrissey on the 18th at noon as well. And then if you know anyone who would benefit from today's session, the session is being recorded, so we will have a live replay of this again tomorrow at 3:30. And then, of course, we have our IP3 session this Thursday at 11 a.m. So that'll be it for this week's session today. If you thought that the content was helpful, please let us know on your way out. Put a comment into chat or come off mute if you thought the content was helpful. It does mean a lot to help inform us of future sessions.